Hello, my name is Galina. I'm a final year medicine student. I recently completed a neurology elective with Dr. Bernard and Dr. Stein in Washington, D.C. with AMIQT. And I became interested in electrical injury as a result of a patient that we had met in the clinic. So I'm going to be speaking about electrical injury pathophysiology, as well as the clinical presentation of an injury that has incurred electrical damage. It's important to mention that more than 3,000 admissions to specialized burn units in the United States each year are due to electric injury. 40% of serious electrical injuries are fatal, and this amounts to approximately 1,000 deaths per year. 2/3 of those affected are construction and electrical workers, and 90% of those affected are male. I always find a basic review of terminology helpful when considering any pathology. To begin with the basics, electricity is the flow of electrons from a region of high to low concentration and potential. When classifying electrical injuries, voltage and current become central to determining the severity of the injury. I really like the analogy used by Ben Newsey in using a water hose to explain voltage and current. In his model, voltage, similarly to water pressure, is the force that drives electrons from high to low potential, creating flow. Low voltage is considered to be under 600 volts, and this can be found in household circuits. High voltage is considered to be above 1,000 volts and is found in power lines and in lighting. Current, similarly to the diameter of a hose, is what determines the volume of electrons that can flow from high to low potential at any one time. And it's defined as the rate of flow of electrons, and it is measured in amps. Direct current occurs when the flow of electrons is always in the same direction. And direct current is used by batteries, railway tracks, automobiles, and it is in lighting. Alternating current occurs when the direction of flow changes on a cyclical basis, so the current flows back and forth. It's found in household circuits. And it is of note that alternating current is thought to be more dangerous for two reasons. The first reason is that it can cause tetanic muscle spasms that can cause an individual to be unable to let go of the source of electric shock, and therefore cause them to have an increased duration of exposure, leading to more severe injury. And the second reason is that the cardiac and respiratory systems are more sensitive to alternating current and therefore may cause higher mortality. The term electrocution refers to the fatality from an electric injury. So when someone receives an injury from an electric current that isn't fatal, we refer to that as electric injury. In terms of the pathophysiology of electric injury, it can occur as a result of direct or indirect contact with an electric shock. Electricity enters through an entrance point, travels through a pathway through the body, and exits through the exit point, looking for a grounding source. So this is illustrated here. It enters through the hand, travels through the heart, down the leg, and out of the feet, finding its grounding source in the ground itself. Hands and heads are common entry points. Hands and feet are common exit points. Of note, in alternating current, these entry and exit points are irrelevant because there is a constant flow of a current circulating into and out of the body out of the same entrance point, as if you will. The common pathways through the body are hand to hand, illustrated here, hand to foot, illustrated here, and head to foot, which is not illustrated. There is an idea that the type of pathway will determine the clinical pattern of consequences and presentation that a patient will present with as a result of electrical injury. So, for example, hand-to-hand pathway will cause higher mortality because the heart will be directly affected by the current, and it could cause cardiac arrhythmia. Pathways involving the head, such as head to hand, will be more likely to cause central nervous system damage. The path of least resistance is the chosen pathway of an electric current. And we know that some tissues have higher resistance, such as bones and fat, and some tissues have low resistance, such as vessels and nerves. Resistance and conductivity are inversely related, so high resistance tissues will have low conductivity and vice versa. This is demonstrated nicely in the table here, which was created by Tran et al., they measured the electrical conductivity of different bodily tissues. And they found that, for example, bone, which has high resistivity, has low conductivity, measuring at 0.0132. And you can see here that nervous tissue, which is thought to have low resistivity and therefore high conductivity, has more than 100 times conductivity of that of bone. We also know that fluid can increase conductivity and reduce resistivity. And this is nicely demonstrated with the cerebrospinal fluid here, which is more than 100 times conductivity that in comparison to that of nervous tissue, which is thought to already have high conductivity. The higher the density of the current, the higher its ability to overcome the resistance, and the more dangerous the current is thought to be. In addition to the pathway and the density of the current, the mechanism and severity of injury is also dependent on the type of current, the duration of the exposure, the voltage, and the intensity of the current. And we can also use the intensity of the current to predict the severity of the injury that the patient is likely to have. So this is a graphic from the 2002 Critical Care Medicine Journal, which shows the physiological effects expected for an individual to experience at different current intensities. And this is measured in milliamperes. So for example, an individual will expect to feel tingling when they have been exposed to current intensity up to 3 milliamperes. At 10 to 12 milliamperes, they will experience pain. And at 100 milliamperes, we would expect cardiac arrhythmias. There are 4 types of injury that can result as a result from electric injury. The first is direct injury, and this usually has respiratory and cardiac sequelae. The second is thermal injury, which occurs as a result of the body becoming part of the circuit. The electric energy is converted into heat energy and therefore cause thermal effects on the superficial and the deep tissue. The effect depends on the resistance of the receiving tissue. So we know that tissues with high resistance, such as bone and fat, will heat up and coagulate, and those of low resistance, such as nerves and blood vessels, will transmit the current. Electroporation refers to the formation of pores within a cell membrane as a result of the application of an electric field to the extracellular matrix, and this will cause cell lysis and apoptosis. And the secondary mechanical type of injury refers to the mechanical injury that occurs as a result of the individual being thrown by the force of the electricity. And these injuries include things like fractures and bruises. The most concerning clinical feature that is non-neurological in nature are cardiac arrhythmias. And these are the most concerning because they account for 2/3 of deaths associated with electrical injury and occur within an hour. These are usually caused by lightning and high voltage exposure. These can present with asystole and ventricular fibrillation. There are benign arrhythmias that can occur, such as sinus tachycardia, atrial fibrillation, and preventricular contractions. And these can present early or as late as 12 hours after injury. The most frequent types of cardiac electrical injuries are sinus tachycardia and preventricular contractions. This ECG is taken from an individual who developed QT interval prolongation and sinus tachycardia after electric injury, which later resolved. Cardiac injury can also present with conduction block or myocardial damage. When we think of connective tissue damage, we are thinking of superficial burns, but skin burns grossly underestimate the degree of internal thermal injury that can occur. So deep tissue burns would be the damage that we would be looking to see if the individual has incurred damage to their muscular tissue and their bone tissue. So for example, muscular tissue damage could present with coagulation and necrosis, or it could present with compartment syndrome due to tissue swelling and cell membrane damage. We can also see destruction of the bone matrix through osteoporosis or osteonecrosis. This is an example of an X-ray taken from a patient 4 months after electric injury, and you can see the cortical thinning, the destruction of the bone matrix itself with these shadowed areas showing bone destruction. We also consider vascular injury, and this is important to consider because it can present with arterial thrombosis, or it can present with aneurysm formation and rupture. And finally, when we think of secondary injuries, we're considering the secondary mechanical injuries, as mentioned earlier, such as fractures and bruises. But a patient can also present with acute kidney injury as a result of the hypovolemia from the skin burns, or mesenteric ischemia as a result of vascular damage. In considering the clinical features of neurological damage, it's important to consider the mechanism of damage to the neurons. And there are four major mechanisms at hand here. The first is vascular damage, which causes vascular spasm and therefore hypoxia and ischemia to the neurons. Then there is the damage incurred from electroporation, as discussed earlier. Free radical damage causes demyelination, and finally, compression injuries due to adjacent edema will result in nerve compression. And so when we see a patient who presents with peripheral nervous system symptoms incurred from electrical damage, we would be thinking of mononeuropathies, most frequently mononeuropathies, and polyneuropathies. These will be patchy, they may be sensory and motor, and they may not be matching in nature. So you can have sensory loss where they may not be motor loss, and vice versa. Patients will also present with neuropathic pain. When we consider central nervous damage from electric injury, we're thinking of central nervous system demyelination, which can cause a loss of motor function. And this can range from hypotonia all the way to quadriplegia. This may or may not resolve, or may resolve partially. As well, a patient can develop an electric traumatic brain injury, which is very similar in pattern to other type of traumatic brain injuries, and can present with symptoms such as coma, paresis, seizures, headaches, nausea, and neurocognitive changes. And when we consider neurocognitive changes, we're thinking of memory loss, behavioral changes, verbal memory and attention changes, and aphasia. This is a functional MRI of a patient who was struck by an electric shock, and it shows the asymmetry of cerebral blood flow. You can see here the lighter areas have less cerebral blood flow, and this is thought to contribute to the neurocognitive changes by Brian et al. Cranial nerves are also often affected, and the most commonly affected cranial nerves are cranial nerve 7, cranial nerve 8, and cranial nerve 2. So cranial nerve 7 are responsible for the innervation of the muscles of facial expression, and therefore an individual will often develop facial asymmetry. Cranial nerve 8 innervates the vestibulocochlear nerve and innervates the auditory and vestibular system, and therefore the patient will present with sensorineural hearing loss, which is demonstrated here in this audiogram of a patient who developed this after electric injury, tinnitus, and vertigo. Interestingly, electric injury can also cause perforation of the eardrum, which would result in conductive hearing loss. Cranial nerve 2 damage causes visual loss, but the vision can also be affected from electric damage as a result of cataracts or intraocular hemorrhage. Other cranial nerves that are affected would be cranial nerve 9 to 12, which can cause bulbar palsy, which can cause an individual to have difficulty swallowing and speaking, and cranial nerve 5, which can result in trigeminal neuralgia. We often think of electric injury as an acute emergency, but it's important to consider the long-term consequences as well, because these are present and they result from chronic damage to the nervous system. And the long-term effects have their own pathophysiology. And there's 3 kind of theories that explain this. One of them is chronic ischemia, which causes slow onset damage. The second is chronic inflammatory reaction of vascular endothelial cells due to free radical damage, and therefore causing a delay in onset of the symptoms. And the third theory is the neurohumoral hypothesis, which does a good job of explaining the delayed and distal effects. So under the neurohumoral hypothesis, the electric current stimulates the release of neurohumoral hormones, such as cortisol, which stimulates the hyperactivity of glutamate receptors. And this causes production of reactive oxygen species, which are neurotoxic. And the combination of these effects in conjunction in Interaction with the vessel walls causes late onset central nervous system and peripheral nervous system damage. And the types of injuries that we'd be expecting to see with long-term sequelae include electrical traumatic brain injury, as discussed earlier. We'd also expect to see neurocognitive and neuropsychological changes. These occur in 78%, as per Wessner et al. These can present with memory and attention changes, irritability, frustration, anger, post-traumatic stress disorder, anxiety, depression. 6% of patients will develop cataracts, and the voltage level for developing cataracts has to be above beyond 200 volts. And finally, we expect to see musculoskeletal effects with neuropathies, chronic pain that is multifactorial and out of proportion to the neuropathy that the patient is experiencing, and contractures and spasms. And this is a table listing some of the common long-term sequelae assembled by Wessner and Hickey. And it's important to consider these when faced with a patient who has been exposed to an electric injury, because they may be presenting with a perplexing pattern of injury. Finally, I'd like to thank you, the listener, Dr. Bernard, Dr. Stein, and the AMIQT staff for allowing me to be present and learn from them and in the clinic. I learned a lot, and I will apply what I learned to my future practice as a clinician. Thank you.